Well, welcome. Today we have Dr. John Tallinger on the Skype. Thank you very much for coming on, John. Whereabouts are you? You look like you're in a woody country.
Yes, in Sweden. I'm actually in my basement. This is my real wood for the winter. It's a makeshift studio that I made. I'm in south of Stockholm, in Småland, the small nation's state, actually.
Okay. So, what's your day job, John? What do you do?
Well, I'm a GP. Been so for about 4 years since I got ready with that.
Yeah. Where did you do your medical training?
In Lund University. Yes.
So you did a medical degree, then you did specialized training to be a general practitioner, doctor.
Yeah.
Okay. Good. And for the last few months, what have you been doing?
Well, it's a little more than 3 months since I started working full time with the project of trying to convince authorities actually to supply oxygen to the care homes for the elderly. That because I got directions sent to me when I was working, and a film that explained how I should care plan all my patients that had risk factors or was over 80, and that they should not be sent to the hospital, but be given palliative care in their homes instead. And this video showed us how we should do it. And there was no mention of oxygen in the video, only that the first thing you do is to give morphine. And of course, I saw a catastrophe coming in Sweden, because if you only give morphine in COVID-19 infection, you're going to see a large degree of casualties. So I was shocked, and then I took my decision to dedicate myself full time. So I'm on leave. Dedicating myself to get the information out into the public, what we are doing, what the directions from authorities say, and how that will influence the death toll.
So basically this is for people over 80.
No, really, it is. It's over 60 if you have a lot of risk factors too.
What sort of risk factors would you be worried about, John?
Well, I think it's not specific, the risk factors, but I mean hypertension, diabetes, all the common risk factors, obesity,
the common chronic diseases,
and even if you had some kind of abuse, narcotics or alcoholic abuse, and chronic lung disease or something like that. So it's the usual that could exclude you from hospital care.
So doctors in Sweden were actually sent like a circular or something saying don't admit these people to acute hospital care.
Yeah, it's. I mean, I have the written documents. It's common practice, and I mean it's in the statements too of people who has gotten it. I just got a hold of a municipality meeting from a municipality in Sweden, where you can hear that the directions are that we shouldn't send these people to the hospital, but instead administer palliative care at home. And I have so many witnesses from all over the country saying the same things. Even one of the first nurses I interviewed as evidence, so to speak, she said that in their whole region, people are not sent to the hospital if they have risk factors or are above 80, and instead they are care planned to get palliative care. And even the witnesses I've spoken to, there's a lot of people who has been care planned without knowing it. And it's in the journal that they should not be sent to the hospital if they are infected with COVID-19, but instead receive palliative care with morphine and midazolam.
So tell us about these drugs. What is morphine, John?
Yeah, well, of course, I don't need to tell you, but I can tell the audience it will damage.
Yeah.
I've been trying to give the information that this is not good drugs. This is not a good drug to give if you have a COVID-19 infection, because it dampens the will to breathe and it makes you quite docile and you won't protest. So you'll soon be, and midazolam is approximately the same. It makes everything looks calm, and
the person feels very calm. They feel good.
I mean, I've said it in videos that I made that, I mean, they will die very happy, but they will die.
So does this policy apply to even younger people with comorbidities, people in their 50s and 60s, say?
You know, no, I don't think so. I mean, the numbers I've seen is that it's 60 with risk factors. So, and I don't have any evidence for people with, because I was afraid for people with, for instance, Down syndrome that have a high biological age, because we're talking about the biological age, of course, to distinguish who is old.
Yes.
Who cannot take the intensive care, which is rough. And I've said it many times, intensive care is really hard on the body.
Of course.
You have to be restrictive if you have a frail patient, but that's not what I'm talking about. I'm talking about simple oxygen, of course, which anyone can get it. But I have no signals of people with Down syndrome, for instance, being denied oxygen.
Yeah. So we're talking about fairly low-level interventions, really. We're not talking about ECMO or people going on high-tech ventilators, or
no.
We're just talking about an oxygen mask slapping on 40% oxygen for a few days.
I can tell you, I've seen the repercussions in Sweden since I went out, because there's been information campaigns where even high up doctors have explained that it's dangerous with oxygen because it's explosive, and that it's dangerous for people with chronic obstructive lung disease. And all of this I have.
Well, that's deliberate anti-science information.
Yeah, I know. It is. And like, there was a doctor who was the chief medical staffer of Gävleborg, who went on tape, and you can see it on my YouTube, saying that it's impossible to give oxygen at care homes because it's so dangerous. It can explode, and it's really, really difficult, and it's really complicated to deliver it, so that people have to be rigorously educated, and it's lethal if you have a lung disease. So it shouldn't be given there at all. And I've been seeing the repercussions of trying to cancel out what I say. But I've been driving on, because and I made a video with my 5-year-old daughter, and we administered oxygen to her doll, just to show the public that this is not rocket science. This is just putting a mask over your mouth, turning a knob. I bought a concentrator for about 130 pounds, just to bring to my studio and show that you put it on, you put the knob on, and then you go. So I invested a lot of money just to show people this is the thing they say is complicated. And of course,
the point is, it's not a lot of money, really, is it? I mean, you're talking about less than $200 American there.
Yeah.
For an oxygen concentrator. And these are, I think we should go back and do a bit of science. Oxygen concentrators are common pieces of equipment.
Yeah.
We use them absolutely routinely in people with long-term lung diseases, because it prevents right-sided heart failure. This is well known, and it's routine stuff. We know that oxygen does not explode. It is not an explosive. Just to clarify that.
Yeah.
Now, oxygen does not burn. Oxygen is not combustible. But of course, it aids combustion. So if there's a fire already, then the oxygen would aid that combustion. But I've been working with oxygen for 42 years now.
Okay.
And and I have never ever had any fires or explosions with oxygen. It's remarkably safe. And I think we should also say that I've taught first-year student nurses how to give oxygen.
Yeah.
You just turn on the knob on your cylinder and you put the oxygen mask on.
Yeah, I taught my daughter to do it, and she's done it with
With a doll.
the equipment. So actually, I can send my 5-year-old daughter to the nursing homes to teach the people.
Yeah. I mean, we have to be careful, obviously, with high concentrations of oxygen in people that have chronic lung disease.
Yeah.
These are people we call carbon dioxide retainers, but this is the minority of people. And even for those people, we can give the oxygen just under a little more supervision. But for the vast majority of people, oxygen is very simple.
As I actually argued, if you have someone with a severe lung disease, obstructive lung disease, and they are suffocating to death, and we see that they are going to die, isn't it better to give them oxygen so that they die of carbon dioxide narcosis? Because that's much more humane than morphine, because it actually, makes them even more happy at the last minute. So there are no arguments against it whatsoever. And
everyone will die through lack of oxygen, whether you've got chronic obstructive pulmonary disease or not. Hypoxia kills human beings. It's that simple. So that's the basic science. Now, what I'd like to know is, do you think this lack of oxygen, this hypoxia that will be caused, do you think that's a common complication in COVID-19 disease?
I think so. I've been studying up on it, and it seems that it's not clear yet what is happening. I mean, we have a combination perhaps of the thickening of the membrane in the alveolar and the microcirculation, but that was just the first intuitive knowledge. Now we know about the thrombosis too. But I mean, regardless if it's thrombosis or a thickening of the membranes, oxygen has to get into the body. So, I mean, of course, I believe that we are at a point where anticoagulants should be given routinely, of course, and that's easy. But oxygen is like the absolute first therapy. And I've seen myself, and I mean, the first patient I met that had COVID-19, he had a remarkably low saturation, and because I was actually a bit shocked because
the levels of oxygen in his blood were very low.
Yeah, it was 84, and he didn't have any dyspnea, and he was
difficulty in breathing. Yeah.
No, and it was quite confusing. That's the only COVID-19 patient I met, but I sent him to the hospital, and they gave him oxygen for 24 hours, and then he went home. But of course, 84 is, I mean, without any, he wasn't affected at all. So something's going on that we really don't know. But what we do know is that oxygen is the first line of treatment, of course.
I think we should just give a little bit of background physiology here. The amount of oxygen that goes into the blood is determined by two factors. In physiology, it's called V and Q. V is the ventilation. It's the amount of air going into the lungs. And Q stands for the amount of blood going through the lungs to pick up that oxygen. There are these two factors, and I'm not telling you this, John. Obviously, you know this. But so if there's a reduction in the blood supply or a reduction in the amount of air going in, we can compensate for both of those by giving additional oxygen. And that will increase the total amount of oxygen that's going into the blood. Therefore, the total amount of oxygen that's going to the tissues of the body. And of course, without the oxygen, the tissues of the body will die. Oxygen lack will first stop the machine and then wreck the machinery. And the brain is often the first thing to be wrecked with lack of oxygen. And I think the other thing to say is when people come in and they have breathing difficulties, putting on oxygen in accident emergency departments, I was working last year, for example, is absolutely routine. It's simple, it's straightforward, it's routine. And you've given an example there of someone who needed oxygen for 24 hours. So was this just with a face mask, John? It wasn't ventilated.
Oh, it was. And the thing is too that you have that because I've been studying up on more because there is that if you don't have oxygen in an area, the blood circulation can shut down as a response to area not being sufficiently effective.
Yes.
And if that person with 84 perhaps had a small segment of his lung with even more blood circulation, that area could shut down, and then that would affect other parts, and then you would have a shutdown mechanism going on.
Absolutely. So what you're saying, John, is that in the lungs, the amount of blood that goes to an area of the lungs is dependent on the amount of oxygen in that area of the lungs waiting to be picked up. And if there's not much oxygen in an area of the lung, then the blood vessels going to that area will constrict. There'll be what we call pulmonary arterial vasoconstriction, and there'll be less blood going to that area. Therefore, less blood going into all of the body. But if we increase the amount of oxygen to an area of the lung, then the blood vessels will dilate and they will go there to pick up the oxygen. So by giving more oxygen, not only do we improve the oxygen in the alveoli, we actually improve the circulation of the blood to the lungs.
It's like the first line of keeping the arteries open are oxygen. But like if they are shutting down even then, I mean, I could fantasize that Viagra would be a good drug with some side effects that wouldn't be unpleasant.
Well, the side effects could be uncomfortable, but yeah.
Maybe an hospital situation.
Yeah. So what John has just said there about the oxygen in the lungs and the ventilation and the blood going through the lungs related to the oxygenation, I think all physiologists in the world will agree with that. I'm sure we won't get any dissent on that. So what we're saying is just giving simple oxygen, low-level intervention for a short period of time could mean the difference between someone dying of hypoxia and someone surviving. And tragically, this is not being done.
It's not being done. And as you pointed out, we have a 10% infection. About 10% are infected. And when we reached 100%, the death toll will be catastrophic in our country. And that's what I'm trying to raise the awareness, so that we have to put pressure on our government to really do something about the situation to save a lot of people right now.
You know, there's other implications of very simple interventions as well. For example, as you probably know, John, in the 1918-1919 influenza pandemic, we don't know how many people died there. It wasn't less than 50 million. It probably wasn't more than 100 million. So we're talking 50 to 100 million people. It's just unimaginable, really. And quite a lot of those people, we'll never know how many, but quite a lot died of secondary bacterial infection.
Of course.
So and again, obviously, when patients come with a viral infection, you have a high index of suspicion that they could get secondary bacterial infection. This is basic medicine.
Not only that, because most antibacterial medications are anti-inflammatory as well, because you use it with acne, for instance, Doxyferm or Arimax. It's probably, we don't know if it's antibacterial or if it's just anti-inflammatory. So the antibiotics could be working at two levels at the same time, bringing down inflammation so that the wall isn't thickened between the alveoli and the circulation, and then clearing out bacteria that are sub-infecting the lung. So actually, the regime for everyone who has COVID-19 should be antibiotic. This is not a time to save up, talk about resistance and stuff like that. Yes. This is not the time to talk.
No, I agree. And we can leave the scientists to invent some better antibiotics next year.
Yeah.
I'm sure they can do that if we spend enough money on it. Yeah. And as well as that, of course, the bacteria will release toxins, and that the toxins from the bacteria will cause an inflammatory reaction as well. And as well as the membrane thickening you're talking about, this could be a contributory factor in what's called the cytokine storm.
Yeah.
Where people get this cytokine storm, they release lots of these inflammatory mediators. And basically what happens is the blood pressure just goes down and they get what we call septic shock. And these people could die.
That we had tried now different types of medication to bring the cytokine storm down. We saw earlier, I think, with NSAIDs that it actually wasn't good.
This is the non-steroidal anti-inflammatory drugs.
Intuitively, it should be. But then when we tried corticosteroids, it seems that it's quite effective in bringing down that storm, the autoimmune response, if you will.
Yes. Yeah, I mean, I think we could spend a lot of time discussing that, and I think there's validity to that. But the point, the main point in my mind is we can give oxygen, we can give antibiotics, and we can give some intravenous fluids.
Yeah, of course.
Now, all of those are very simple, basic interventions. They're very low cost.
Yeah.
And I think, I mean, we know in this disease that maybe 80% get asymptomatic or very mild symptoms. We know that 15% get more severe symptoms and 5% get critical symptoms. So perhaps without this treatment, I think all of the 5% critical ones are going to die.
Yeah.
But the point is a few percent, maybe another 3-4% of that 15% that get quite poorly, they could potentially die without these minimal interventions just for a short period of time.
And another point, I'd like to make another point, because I can prophesize that in the future, a big part of my work is going to be taking care of the people who have survived but has extensive lung damage or internal organ damage. So I'm going to be turned into a lung clinic the medical cost of the future, taking care of all these patients damaged because of insufficient care, even in care homes, because the one that survived is going to be even more expensive if you want to be crass about it.
Yes, yes.
If you just talk about healthcare, sure, you'll save people on the people that die because you don't have to give them pension and take care of them. But on the other hand, the ones who survive is going to be more expensive. So we don't know.
We simply don't know that, but a lot of information is leaning towards that. And the other thing is that these receptors where the COVID-19 virus goes onto, these ACE2 receptors, we know they're actually found all over the body.
Yeah.
So potential for damage to other organs. And we also know that, for example, troponins are raised in severe COVID infection as well. And as you know, troponins are an indicator of damage to the heart muscle itself. So we could be left with residual lung damage, residual heart damage, residual kidney damage. And that's one thing we don't really know yet. I mean, let's hope it's going to be a very small percentage. But the answer is we're not really sure about that yet. It's kind of one of those unknowns.
A doctor's role in healthcare is always to think the worst first. It's like that's our job, to always think about cancer when we have someone. And if there's a virus, our job is to think the worst of the virus. And then if it turns out it wasn't that horrible, then we're wrong.
Nothing lost. Absolutely, yeah. Medicine should be intrinsically cautious, shouldn't it? Yeah. You know, the other thing that concerns me is we've got these three simple interventions: the oxygen, the antibiotics, and the fluids. And in many other parts, I mean, Sweden's a sophisticated country. It can do all these things if it chose to do so.
Yeah.
But in many parts of the world, I mean, I've worked in situations in Asia and Africa where these simple interventions aren't available to a lot of poor people at the best of times.
Yeah.
And it just seems to me that the world really needs to have a major move to make oxygen, antibiotics and intravenous fluids available to everyone, because this could save untold millions of people just with these simple interventions. So perhaps rather than getting Formula One teams to make ventilators, which is good to get them.
Horrible that I actually learned that Tegnell is together with, because I have a friend now in India who's high up, and he's shown me that the foreign state department in India has invited a webinarium between Tegnell,
like an online conference thing,
online conference, to actually where Tegnell is selling the Swedish concept to India. And if he would be able to sell his strategy in a country with 1.3 billion people, that would not be a humane thing.
Really? So it's almost like a political attempting to influence the political opinion in India. That's
yes. Sweden is trying to influence other countries politically to adopt their strategy as a means of coping with, as a means of not coping with COVID-19.
Yeah. So what are the restrictions like in Sweden at the moment, John? Are things still fairly locked down, or is the?
I mean, honestly, there are no restrictions at all. I mean, you saw there was a protest here. I don't want to get political, but it's called Lives Matter, and there was thousands of people in the street tied up together, and the police didn't separate them. And I mean, everyone who's outside, I mean, 50 people. My God, you can actually be 50 people in a tightly packed restaurant. I went to Stockholm, and everyone is tightly packed in restaurants. No one has face masks. There are no restrictions. The only restrictions I see that is really enforced is that members of the family cannot visit the people that are in care homes, so they're dying of broken heart, more or less.
Yeah. So basically, de facto, Sweden is adopting a herd immunity strategy, whether it likes it or not.
Well, to deny that is beyond my ability to describe. I mean, it's not only is it herd immunity, it's enforced herd immunity, because there's been almost propaganda hits on state television saying how dangerous face masks are. And I mean,
wow.
Ed Tegnell actually said that it's really dangerous because that there's a lot of bacteria that are gathered that are dangerous, and if you touch the face mask, you can spread the disease more than if you don't have a face mask. So they are actually saying don't use a face mask. So people actually don't. And if you go out with a face mask now, you're so ostracized with that, it's almost impossible to move around. When I was in Stockholm, I can tell you, we went into a store with face masks, me, my wife, and my daughter. And the cashier, she got so upset from seeing me in a face mask, because I think she thought I was going to rob her. And I've heard stories that people are pointing their fingers and laughing and saying, "Hi, he's got a face mask" in the street. So you're harassed actively if you have a face mask, because it's been pumped out into society that face masks are wrong. They're not good. They don't protect you, and they're actually dangerous, and all of that. So it's like you can't leave the house with a face mask without being looked upon like you're a crazy person. So it's not herd immunity. It's enforced herd immunity. It's like herd immunity on steroids. You know what I mean?
I do, absolutely. Yeah. I mean, all the countries we've looked at in detail on this channel, for example, in Taiwan, face masks wearing universal, virtually no cases. South Korea, face mask wearing universal. Japan, face mask wearing universal.
In Sweden, it's considered a myth.
Yeah. Cambodia, Thailand, Singapore, Hong Kong, we could go on. The countries that have had the most success all wear face masks, because you and me know that a face mask is going to stop an infected person spreading the virus out for a distance away from them into the air.
Yeah, of course, it protects what it protects. I mean, even if it's a thin sheet, it's going to protect against the aerosolization, and the cloud isn't going to be that stormy into
absolutely.
It's going to be closer to you, the
absolutely.
cloud.
And we've given evidence for this time and time again on this channel that the science. The science is there. The science is there. The epidemiology is there. The common sense is there. Even the British government now, it's mandated to wear face masks on public transport now.
I made a point on my Facebook page that because I have pictures of the 1918 Spanish flu, and all the people are wearing face masks, and I think it was mandatory in some states, and they didn't even know it was a virus until the 1930s.
Is that right? I didn't know that. Right.
They had no idea. They didn't know what it was because they couldn't see it in a microscope.
No, of course not. I mean,
So
we forget how recent to science virology is.
Yeah, so like in the 30s, I think they went to the corpses and they showed that, oh, it was a virus. So even before they knew it was a virus, they knew intuitively to use a face mask. But now in Sweden, more than 100 years later, we don't have the common sense anymore. It's fascinating.
It's very interesting. I mean, so the people then just knew from their empirical observations and their common sense without understanding the virology. That is so interesting.
It is really interesting because we are smarter than we think if we just let our common sense guide us. Someone must have observed that there's some magic in the air, intuitively, and maybe we try this and it worked. Yeah. And in some states in the United States, it was a law to have them. And in other states, it wasn't. And of course, you can guess which ones died in herds.
We can learn so much from history, can't we? From the history of
amazing.
Just so much. Mm. Yeah, I mean, we forget. I mean, bacteria weren't identified till about Louis Pasteur, maybe the 1890s. And virology is a really recent science because these things are so small, of course, that they're 10, 20 times smaller than a bacterium. So you need an electron microscope to see them. Mm. So how do you see things going in Sweden now? I don't want to put words in your mouth, John, but you tell me how you see how do you see 2020 playing out in Sweden?
I see that there is an unwillingness from the ruling party to do anything about this, even though they know the problem. So it's going to be dragged out, and either that side wins, and we see a genocide of which we have never seen, and a scandal, or
I've never heard that term, genocide. It makes perfect sense, doesn't it?
I looked it up. It means to actively kill the elderly or abandon them to death.
Yeah.
So I've chosen that word to describe even because it's intuitive. Genocide.
Absolutely, makes perfect sense. Yeah.
So I'm trying even to coin, so to speak, that term in Sweden to describe the situation. It's a genocide going on, and I'm hoping that I and others, because there are a lot more than me that are fighting this battle, can get the word into the public in a way that that the discussion is so loud that there will be consequences politically, or forcing the ruling party and the prime minister to actually do what I'm proposing, to make a national effort to get oxygen to all who needs it. So we have the hashtag oxygen for all who needs it implicitly. It's an information campaign, of course.
So what I would see happening, given that there is this community spread in Sweden now, and given that there's a lack of social distancing, and people are basically just ignoring the virus in so many ways, I would expect the number of cases to increase very quickly. Mm. And I would also expect the proportion, the 15% or so that get quite ill, to increase quickly. Mm. And I would expect the 5% that become critical to increase fairly quickly. So what I would anticipate in the next weeks and months in Sweden is we'll see lots and lots of cases, lots and lots of people getting sick, and tragically a lot of people are going to die fairly quickly. So I think there's an element of urgency in what you're saying. This needs to happen now.
Ow.
We have not got time for this. We need to be fast. In detail, John, what are you proposing? What should be done?
I'm proposing that, and I've said this since 3 months, Stefan Löfven, the prime minister, should get up on a press conference and say, look, we have a problem. We have to solve this together. I'm calling out to industry to help. We have the money. You have the means. We're a highly industrialized country with a lot of factories producing oxygen. Let's get to work and give oxygen to all who needs it. and I think we can do it in 2 weeks.
Wow. So rather than Formula One teams making ventilators, which was a good idea at the time, given what we knew, we should now have Formula One teams and all the brilliant engineers working on simple, basic oxygen concentrators and oxygen therapy.
I mean, you don't even have to make concentrators. Liquid oxygen is an excellent way of delivering it. You just need a canister, and you fill it with liquid oxygen, and then you supply it, and it's quite an easy system, because you just go with a truck to and fro and fill up the tanks. That's how you deliver oxygen, of course, in the hospitals. There's a huge tank with liquid oxygen, and you can have them smaller, and you can move them around, so you can actually drive the oxygen and then you can buy all the oxygen concentrators. So you can have a lot of different options,
different approaches, to
supply it. I mean, at the factories, you could actually put big military tents and just put, the hoses from the factory into those tents. There's a lot of different things you can do.
Actually oxygenate the environment, have a high oxygen tent.
Yeah, I've been talking to an intensive care doctor about that. We could put tents and just have 100% oxygen or 95 in them, and just put people in there. You just roll them in and they breathe, and then you roll them out when they're better. Because we have an abundance of oxygen, because we have factories. Countries who don't have factories are not in a good situation. But actually, we have a lot of factories.
We have, yeah. So what about the antibiotics? Do you think they would be available?
Yeah, of course. I haven't been talking about it because I've been adamant to have one message, because
in
the media landscape, one doctor has one message, maybe he can get it out, but if I have two messages, it's going to be complicated.
But between you and me, we know that antibiotics and intravenous fluids are not a problem.
No, it's not.
No. If we wanted to put a drip up on every single person in the world, we could probably do it within a couple of weeks.
Yeah, sure, of course.
Yeah. John, on this channel, we like evidence. So what I'd like to put at the bottom of this video is the evidence for the things that you are suggesting. So
no, I have it edit, because I have a home page now.
Yeah.
And I have a small eye where you click, and I put all the evidence there, so it's there. You can just go through it if you're a reporter.
We will, and we'll certainly post the links to that, so that what we were saying is evidence based, because
everything is on my webpage. The link to my YouTube channel, Facebook, and all the news in a simple manner.
We'll put some direct links in as well. I think that would be useful. So I think the last question I wanted to ask you, John, is what message? You see, at the moment, the World Health Organization have said that between 1% and 10% of the population of the world have been exposed to COVID-19. That means that potentially 90% of the world could still get infected. And herd immunity probably won't be effective until 70 or 80% of the population are affected.
We don't know, or at all.
No, that's right.
We don't know.
No, you're saying that we don't understand how immune someone will be after this.
No, we don't, because you don't know if you get immunity before you get it. I mean, the Norwalk virus, for instance, you're immune for 1 month. We don't know if this gonna mutate to the next year, so that we're not immune to the mutated form. So talking about herd immunity when you actually don't know.
We don't actually know. Yeah. So many things we still don't know, isn't there? It's true, absolutely. But what is your message to the rest of the world from what you've learned from the Swedish experience? If you were just making a few points now to tell the World Health Organization to implement everywhere in the world, what would you tell them?
Well, I would like to work vigorously to stop the virus, to eradicate it, like smallpox. Eradicate the virus. That's the first message, obviously. And at the same time, while doing that, trying to get oxygen to as many people as possible around the globe. That's the two messages I would suggest.
Yeah, and I agree. I think getting the main way we can save lives now is to get oxygen to as many people that need it as possible.
Mm.
And we can do that with these remarkably simple devices, these oxygen saturation probes.
Yeah.
We know what someone's oxygen is. They're $20. We've shown them off on this channel many times.
It's so
and we can titrate oxygen therapy with that, and oxygen for the vast majority of people is a completely safe thing to do for a short period of time. No, our Prime Minister, you probably know, Boris Johnson, we think he was on oxygen therapy for about 3 days. He wasn't CPAP'd. It wasn't the continuous positive airway pressure. It wasn't the ventilation. It was just an oxygen mask for 3 days. And I
was very happy because it got publicity. Oxygen got publicity for me.
Without that, he would probably have died.
Yeah.
By giving simple oxygen therapy, he's made what looks like a good recovery.
Yeah.
And that is so if Boris Johnson's listening, Boris, you had oxygen, it saved your life. Part of your mission now is to get oxygen to everyone in the world that needs it, and do whatever clever things you can with the United Nations, with the World Health Organization, with other governments. Use the full force of the diplomatic service and get that message out to the world. Simple oxygen therapy.
Can I ask Boris Johnson for one thing?
You certainly can.
Boris, please call our Stefan Löfven and tell him to give oxygen, or there will be diplomatic consequences.
Good. In fact, we'll tell everyone. Should we tell Donald Trump as well if he's listening?
Yeah. Both.
And anyone, just
anyone
that has power, please listen to us. We are convinced this is how lives will be saved, and that's what.
We know that. We're not only convinced. It's science.
It's science, absolutely, John. John, thank you so much for that. I feel quite emotional now with that. The simplicity of that message.
Yeah.
And it really is. When you kind of get that weird feeling at the back of your neck and things, it's this is we can do this, and it's just it'll be such an indictment if we don't do it.
We put a man on the moon, for God's sake. 19, what was it? 60. Yeah. I mean, can't we do this? Oxygen for everyone?
Absolutely,
separate it out from the air, and then the people consume it, and it's let out again into nature. It's like it's the perfect.
It's the most natural thing in the world, isn't it? Yeah. And if this is not done, what an indictment this will be on humanity, that these simple things.
Sweden will never recover if this goes through.
Yeah. I mean, what is the point of having science if we don't use it to save human lives? We might as well go back to the Stone Age.
Now, I'm comparing to Germans who 70 years after the Holocaust is still feeling guilty about what happened, even they are 20 now and they still have guilt because of their parents. I mean, similarly, I'm not trying to compare. I'm trying to compare the morality of it, that we will be ashamed forever. For a long time, if we don't do something now. So it's a bit soul saving for the community soul of our country to actually stand up now for the weak and elderly and not be forever in shame.
And I've said many times, civilization can be defined as how we look after the most vulnerable in society. Yeah. John, thank you very much. We'll hopefully we'll talk to you again. We're going to put evidence at the bottom of this. This is not just you and me chatting. It's this is the science as we both understand it. And I really appreciate your time and thank you. And God bless you in Sweden.
An honor to speak to you.
It's a pleasure.
Mm-hmm.